with enormous pleasure, I would like to welcome Professor Ali Hajeer, who's the Laboratory Director at the King Abdulaziz Medical City. And it's a great privilege to have our very esteemed colleague join us and talk on serology testing for MERS-CoV and SARS CoV2 infections from Saudi Arabia. Thank you, Professor Hajeer.
Thank you so much, Professor Martin. Thank you, Kelly. Thank you, Dr. Osborne, and everyone at the organizing committee for this interesting day. Thank you, everyone, for joining us today. I'll take you through a journey of serology testing for coronaviruses. And as you know, coronaviruses are enveloped single-stranded RNA viruses. The new SARS CoV2 virus belongs to the beta genus of the coronavirus family, and it is in the same group of coronaviruses like MERS, SARS-CoV-1, where BAT is known to be the primary source for these viruses, and different intermediary hosts for the different viruses. For example, for the MERS, we have the camel. For SARS-CoV-1, we have the wildcat civets. And for SARS-CoV-2, it's believed that the pangolin or the anteater is the intermediary host for this virus, although there is some debate about that. These viruses in the beta coronaviruses, MERS, SARS-CoV-1 and 2, they share a similar sort of structure where we have the envelope virus with S antigen, E antigen, the envelope antigen, the N antigen, nuclear antigen, and the S antigen where the virus binds to the host cell to gain entry inside the cell. The genetic structure is almost similar for all the three viruses, where we have the open reading frame, the S gene, the E antigen, the M antigen, and the N antigen. It is interesting to note that there is very little cross-reactivity between the genomes of these viruses, especially when it comes to the protein level. And when we look at the percentage of homology between SARS-CoV-2 and SARS-CoV-1, there is a big homology in the N antigen and the S2 part of the S antigen, while there is a very little, less than 50% of homology with MERS-CoV, with other beta viruses or alpha coronaviruses, for example, where there is a very little sort of homology with SARS-CoV-2. And this was translated with serology assay, where people looked at ELISA assays, where they have the S antigen, S1 antigen for SARS-CoV-2, and the RBD antigen SARS-CoV-2 as well. And they tested sera from patients with SARS-CoV-1, MERS-CoV, and other coronaviruses. And they only noticed some homology or some reactivity with SARS-CoV-1 sera, and not MERS-CoV, for example, or the other coronaviruses. So to summarize this, there is little homology between SARS-CoV-2 and the other coronaviruses, with the exception of SARS-CoV-1. So if you are doing assays, the chances having a false positive assay due to other coronaviruses is little in this case. In this slide, I'm trying to show a comparison between MERS-CoV and SARS-CoV-2. So MERS-CoV is the Middle East Respiratory Syndrome. It was identified first in Saudi Arabia in 2012, and it spread to about 27 countries with confirmed cases 2,494, a total death of 858 with a fatality rate of 34%. This is compared to SARS-CoV-2, the virus that we are suffering from now, which hit more than 216 countries and with more than 50 million cases affected. This is as of today, this morning, and more than 1.2 million people died from COVID. That gives it a fatality rate of 3%. So although the fatality rate is different between MERS and SARS-CoV-2, luckily, the fatality rate in SARS-CoV-2 is about 3%, but the spread of this virus is everywhere. When it comes to the serology and the markers of the disease in SARS-CoV, and that applies to MERS-CoV and SARS-CoV-1 and 2, we have the early appearance of the RNA viruses in the lung and nasopharyngeal samples, and that with time start to goes down. As it is going down, we have the IgM antibodies going up, and the antibodies IgG, IgA starting to go up, with memory cells and persistence of antibodies for some time. It is very interesting to note that the antibodies to both MERS and SARS-CoV-2 decline with time. And we noticed in our setting, where we have in our hospital more than 270 healthcare workers infected with the MERS-CoV, after 1 year of symptom onset, none of them had the antibodies to MERS-CoV. The antibodies completely disappeared. And this slide shows the kinetics of antibodies in MERS-CoV, where in mild cases, you don't have high levels of antibodies, but they start to disappear very soon, after about 20 weeks after onset. And in severe MERS-CoV, you have higher levels of antibodies, but that again start to decline with time. And this is from a recent paper on SARS-CoV-2, where they compared asymptomatic and symptomatic cases. And with the acute level, the acute phase, you'll have higher antibody levels compared to the convalescent phase of the infection, and that usually within 8 weeks. So you have a drop in the antibody levels in the acute phase to convalescent within 8 weeks. You start to notice a drop in the level of antibodies. In our hands, for mild cases, we found most of them, they actually lose their antibodies, and that starts 4 to 5 days post symptoms, starting of symptoms. And in the same paper, they looked at asymptomatic versus symptomatic. Asymptomatics, they lose the antibodies, almost 40% of them, they lose the antibodies within 8 weeks completely. They become negative. Compared to symptomatics, only 12 or 13% of them, they lose the antibodies within 8 weeks. There's this paper that described the in New England Journal of Medicine, the rapid decay of antibodies. And in this paper, they noticed that within 3 months, the antibodies start to disappear in patients, especially in asymptomatic patients. So when do SARS antibodies appear and disappear? It is very important to realize the assay that you're using and when the antibodies can be detected. In this paper, they found that antibodies start to be detected about 10 to 14 days of onset. And after that, actually, they start to disappear. I'm not sure if you can see this, the figure on the right, where the red lines in the severe cases and the black line in the asymptomatic cases. And the antibodies start to disappear after that. So in MERS-CoV as well, we noticed, as well as many others in this paper, people noticed that there is a relationship between levels of antibodies, whether it is IgG, IgA, or IgM, and there is a correlation between these specific antibodies to MERS virus and severity of the disease. This is exactly the same picture we saw in our hands, in our hospital, as well as many other reports around the world, where antibodies to corona, MERS, or SARS-CoV-1 or 2, they correlate with disease severity. And this is very important. This is a study on SARS-CoV-2, IgG and IgA level. And as you can see, the IgA levels, specific IgA levels, they correlate with disease severity, while in mild disease, you see lower levels of antibodies, and that applies to IgG. Interesting to know that, look at the titers. The titers of the IgA antibodies were much higher than those for IgG levels, even with severe cases. And this case from the same paper just reflects on severe cases and the higher levels of IgA and IgG over time from onset compared to mild cases. Severe cases, they seem to have higher levels of IgA and IgG levels. Look at the titer and compare between IgA and IgG, and the time period, they stay longer, while in mild and asymptomatic cases, they seem to lose the antibodies much quicker. This paper looked at the IgA and IgG levels, and they looked at IgG-RBD antibodies, IgM-RBD, IgA-RBD, and they found a very strong correlation between two things, disease severity as well as death. So if you look at this RBD antibodies, you see that they're in the deceased cases, they had much higher levels of the IgG antibody to RBD domain of the virus compared to intubated, which show the same, while hospitalized and mild cases, they have lower titers. So from this paper, it is very interesting to note that levels of IgG, IgA correlate with disease severity as well as outcome. Which antibody assay? This paper looked at the assays from 6 different commercial kits, and they used S and N antigen. They found them to be the best antigens to be used in these assays, and they found that automated immunoassay have better results than ELISA or manual assays. Which antibodies are more important in COVID-19 infection? We know that SARS-CoV2 or COVID is a respiratory disease, and we know that IgA, especially secretory IgA, plays a major role in these diseases. And people noticed that IgA levels, actually, if you look at most papers looking at IgG, IgA, anti-SARS-CoV2, you see higher levels of IgA and persisting for longer times. What about rapid assays? Rapid assays in general, they suffer from lower sensitivity. And in this paper, people found that the sensitivity of rapid assays are between 10 to 55%. That increased after 11 or more days post symptoms. And this puts a big question mark about rapid assays. I'm not going to go deep into this, but this is a very interesting paper where researchers actually followed corona, the normal corona, the common cold corona. They followed people over 35 years, and they noticed something interesting, that people looking at antibodies, people have sort of ups and downs with the antibodies correlating with infection, and they found that people can be infected actually once every 6 to 12 months. This is the normal common cold. And this is looking at the different antibody levels in the different coronaviruses, the common cold, and compare it to measles, where the antibody levels is very tightly preserved, while in the other corona, you have the antibodies varying over the years. And this suggests that there is an issue with the antibodies, that although you have the antibodies, still people get the infection again and again. And some people actually advocated the presence of what we call antibody-dependent enhancement of coronavirus, that the antibodies can help the virus gain entry into the cell. And sometimes those antibodies, especially the low titer, they may be actually pathogenic rather than protective. So rapid decay of the antibodies, what effect does that in immune passport? We heard about the herd immunity and COVID, and a new paper actually looked in JAMA at calculating the percentage of people that need to be immune to get the herd immunity, and to calculate that, it's 1 minus 1 divided by R naught. And for SARS-CoV-2, they calculated that you need up to 50 to 67% of the population to be immune to reach what we call herd immunity. So to summarize, How can we utilize serology in SARS-CoV-2 and MERS-CoV infections? Serology for these coronaviruses can help us follow up on patients. They can give us a good idea, especially with patients receiving convalescent plasma. It's a better understanding of the immune response, can help in epidemiology study. What about diagnostic? I think SARS-CoV and MERS-CoV viruses, they cause acute respiratory infection. And in acute respiratory infection, you need something that can detect the virus early in its disease. So you don't want to give it 1 week or 2 weeks. So the best thing in that case is a PCR. However, antibody can help. And I'll show you my final slide in a minute. So to conclude, natural infection with SARS-CoV may not give rise to long-term immunity. And this puts a question mark about herd immunity. Serum IgA-specific antibodies may be very helpful in epidemiological studies as well as in diagnostics. It's interesting that when we hear about people talking about vaccine and talking about convalescent plasma, they always talk about IgG, IgM. You don't hear people saying what levels of IgA antibodies are achieved there, and I believe that should be taken into consideration. Antibody titers are linked to disease outcome, so we can use the antibody in patients, especially hospitalized patients, to predict outcome and mortality in certain cases. Antibodies may be a support for PCR. We know that PCR with time start to go down, especially 13 to 15 days post infection. And in that case, serology can be helpful in monitoring and detecting these cases. With that, I stop here and thank you for your time. Thank you.
Professor Hajeer, thank you so much. That was an absolutely scholarly review of the field and very much appreciated. So the first question that we've had in was one around which serology platform do you know? Do you use?
It's very embarrassing to say anything about companies. I don't want to mention companies because of conflict of interest. But what I would say that we use in our lab chemiluminescent sort of automated assays. And people in the paper I showed, they compared those automated assays like chemiluminescent assay with manual ELISA assays. And they found that the automated chemiluminescent assay are more sensitive than the manual ELISA type of assays.
There's been some work with the National Institute of Biological Standards Control in the UK, which has shown 100-fold difference in sensitivity between some of the different automated platforms. Yeah. So that was why I was asking that there are several that appear to be less sensitive than others, and it doesn't seem to be dependent on the antigen target. We've also got questions about do you know if any of the vaccine programs are now starting to look at the IgA response?
I looked at the published paper, not the one that Pfizer is doing now, but I looked at the published data, and usually they measure IgG and IgM levels. And I believe definitely that we should take into consideration the levels of IgA induced by these vaccines as it stays longer, much longer than IgG. And I believe for this type of respiratory viral infection that it will have a major role in terms of fighting the virus and protecting people.
Okay, thank you very much. And we've had a question also about elaborating how antibodies enhance viral entry into cells.
That was a proposed mechanism for why people, they get the reinfection, for example, despite the fact that they still have antibodies. And this mechanism of enhanced antibody entry of the virus was proposed before COVID, and some people, they did some work on that, and they found that low affinity antibodies, low titer antibodies seem to enhance the viral uptake by the cells. And there are so many proposed mechanisms. I didn't want to go really deep into that. I have the slide taken from that paper, from a paper that shows, for example, complement and other sort of mechanism that can help uptake of the virus by these antibodies.
Thank you. So you have lots of compliments on your presentation too.
Thank you.
Do you believe that herd immunity can be applied even though antibodies are disappearing?
It's very difficult to answer this question. My personal belief is that unless we get a vaccine that can induce a long lasting antibody and immune response, I believe by natural infection, we will lose it. We looked at a cohort of patients who got the infection, and actually those with mild symptoms, very mild symptoms, they lose the antibodies 40 days, 45 days after infection. So can that lead to a herd immunity? I have my doubts, but I believe a vaccine should really give us that hope. But this is personal view.
Thank you very much. We've had another question. I think that covers one of the other questions, and the other one was around titration of antibodies in convalescent plasma studies. So is there, I think there is an antibody titration, isn't there, for convalescent plasma?
Yes, yes. Actually, we did that with ELISA in our lab, and we did a major study with MERS with convalescent plasma. But I must say, we published 2 papers, and there was negative result out of that. I must say that we did not have really a positive sort of effect from the convalescent plasma. But to go back to the methodology, yes, you can titrate it, and you can titrate it using the ELISA. I mean, it is a very simple type of procedure.
Okay, thank you very much. We've got questions still coming in thick and fast. There is a question about antibody response to COVID and the upcoming vaccine programs. I'm going to add a little bit of my own on that one. So the reports of mink carrying a mutated version of the spike protein, what implications do you think that might have for the vaccine?
I think it's early. It's really early to make any scientific conclusion on that. Yes, the mink version of this virus has the mutation, but we still need to see serum from people who were infected with these viruses. And similar to the slide I gave at the beginning, showing the cross-reactivity between the different viruses. I mean, unless we do these studies and see that there is a cross-reactivity or no cross-reactivity, it's difficult really to make a scientific conclusion now.
Okay, thank you. Thank you very much. There's the final question was just to confirm that IgA assays are available.
Oh, they are commercially, absolutely. Many of them.
Okay. Thank you so much. Well, that was an absolutely wonderful, wonderful presentation and very much appreciated.